The breath, bear down, swallow as hard as possible. Give a demo along with some examples wherever applicable. Swallowing therapy, there are different strategies. Supraglottic swallow. So it goes like this. Sixth is Masako maneuver. Today we will discuss a very important, very interesting, but most ignored topic in medical care, that is swallowing therapy. These techniques are very useful for people after stroke, after head and neck cancer surgery, and head and neck radiation. So, step 1 in swallowing therapy is always swallowing assessment. Functional endoscopic evaluation of swallowing is the most useful test to evaluate the swallowing system and to plan the therapy. We can't do a proper therapy without this. Step 2, in swallowing therapy, there are different strategies depending on individual scenarios. I will give a demo along with some examples wherever applicable. First strategy is dietary modification. In general, obstructive diseases they cause dysphagia to solids more than liquids, and neurological diseases cause dysphagia to liquids more than solids. Also, liquids have a greater chance of aspiration into the airway. So, if there is aspiration or injection, like in superior laryngeal nerve palsy, vocal cord palsy, stroke, we should stop liquids and start on semi-solid diet. If needed, Ryle's tube can be inserted to give liquids. Secondly, we can use thermal stimulation to activate the oral phase of swallowing by using cold stimulus like crushed ice. Second strategy is range of motion exercises. These exercises are basically meant to strengthen the muscles involved in swallowing, like lips, tongue, cheeks, and throat muscles. For example, for tongue, we can practice moving tongue up and down, side by side, sliding along the palate, pushing against resistance like a spoon. These are useful in cases like stroke, facial nerve palsy, after hemiglossectomy. So, suppose after we do a hemiglossectomy, even if we use a free flap repair like radial forearm free flap or ELT, anterolateral thigh flap, the flap can fill the defect in the oral cavity but it cannot move. The flap doesn't have muscles. So, we have to strengthen the remaining half of the tongue so that the oral phase becomes normal. So these exercises are very important, especially after stroke or oral cavity surgery. Third strategy is postural variations. We can use certain postural adjustments also, head back or chin up. After taking semi-solid, if we tilt the head back and keep the chin up and then swallow forcefully. So here we are using gravity to push the food bolus into the throat. So it is useful if the oral phase is found to be defective. And how do we know that? So oral transit time will be increased on feces and there may be food residue in the vallecula. Second postural strategy is head turn. If there is disease on one side involving the larynx or hypopharynx, we turn the head to the affected side. This will open up the normal opposite side so that food can pass down easier into the esophagus. Suppose there is disease on the right side of the hypopharynx. So we should turn the neck to the right side so that the left side opens up. We have also noticed in our practice that if suppose there is laryngeal paralysis of the left side, patient will tend to cough if he lies on his left side. Because due to paralysis of the superior laryngeal nerve and recurrent laryngeal nerve, saliva and secretions they can trickle down into the windpipe when patient lies on the affected side. So we can ask the patient to sleep on the normal side to prevent such coughing. Third postural strategy is head tilt. Tilting the head towards the stronger side or the normal side. It can help move the food bolus better. But we cannot do excessive tilting. Fourth strategy is swallowing maneuvers. Now there are a variety of maneuvers to help us. First is effortful swallow. Basically, we use all the muscles in the throat to push the food as hard as possible, like this. So, this will help to strengthen the pharyngeal muscles. Supraglottic swallow. This is used in cases of mild aspiration. Practically, we use it after supraglottic laryngectomy or epiglotectomy. Step 1 is to inhale deeply and hold the breath. Step 2 is to swallow forcefully. Step 3 is exhale and cough. Let me show you. So the principle behind this is that when we inhale and hold, we close the glottis to prevent aspiration. And after swallowing, we exhale and cough to push out any food residue out of the windpipe which may have entered. Third is supraglottic swallow. This is similar to supraglottic swallow, but here we, in addition to supraglottic swallow, we do a bear down motion. Bearing down effort will further close the glottis and help to prevent aspiration. So it goes like this. Like this. So we inhale, hold the breath, bear down, swallow as hard as possible, exhale, and then cough out. So this was supraglottic swallow. Fourth is Mendelsohn's maneuver. So here you swallow and hold the Adam's apple at the highest point for 3 to 4 seconds, like this. Fifth is shaker exercise. It's very simple. Just lie down on flat bed, raise your head while keeping the shoulders flat on the bed, and try to watch your toes. So basically it will help to strengthen the neck and strap muscles. Sixth is Masako maneuver. So here you stick your tongue out, hold it between your teeth, and then swallow, like this. These swallowing exercises which we have discussed, they are obviously not comprehensive and you should never try it without your therapist. I hope this discussion will help our ENT colleagues, neurology colleagues, and our speech language pathologists also. We should all join hands to create swallowing programs in our clinics. Just doing head and neck cancer surgery, head and neck radiation, or even stroke treatment, it does not give a optimum quality of life to our patients. Swallowing therapy greatly increases the quality of life and makes the patient independent. Also, it prevents a number of complications like aspiration pneumonia, and also it helps to make the patient self-dependent. And mentally also the patient feels more comfortable when they are able to swallow on their own. So this is a life-changing thing. It's a very simple program which we should start in collaboration with our speech language pathologists, ENT colleagues, neurologists, and maybe sometimes gastroenterologists also.